My name is Naor. I'm the Deputy Director of the International Vaccine Access Centre here at Johns Hopkins University, and pleased to have you all on board. We have a great lineup, really fantastic speakers today. We have Andy Pekos, who's a Professor of Molecular Microbiology and a virologist who well, since the advent of the pandemic has become really a leading expert in SARS-CoV-2 virology. And also joining us today, we're very lucky to have him, is Tomoshima Bakuro, who is responsible for safety surveillance at the CDC and is heavily involved in the VAERS systems and other safety systems for COVID-19 vaccines deployed in the US. So hope to have a great discussion, and please do address your questions in the Q&A. We'll hope to get through them. We also received some already previously in email. Next slide, please, Andrew. So just a brief introduction to IVAC, to the International Vaccine Access Centre. We're a centre that resides at the Johns Hopkins School for Public Health in the Departments of International Health and the Departments of Epidemiology. And we deal with the sharp end of the stick, if you like, or the pointy end of the needle with respect to vaccine pipelines. We're engaged in all manner of aspects of vaccine deployment relating to broad eight practice areas, broadly speaking. We provide country support for the preparation and introduction of vaccines. We have programs that evaluate coverage and equity in vaccine distribution. We provide technical assistance and advocacy to countries for introduction of vaccines. We review the economics of vaccines and financing of vaccine programs, and that overlaps with operational research. We provide policy support and engagement with communities and with policymakers at every level of the global public health community. And we are involved in international programs to evaluate disease burden and to look at disease epidemiology, both emerging diseases and existing endemic diseases as well. Once vaccines are introduced, then we've been involved very heavily in impact and effectiveness evaluation in real-world settings. And all of these practice areas providing support for countries and indeed for international collaborators and development partners across a whole range of disease programs. Some clearly overlap across diseases and are system-wide issues, and some are specific to specific antigens and specific diseases. Fundamentally, the underlying principle is that we want to develop the best available evidence to translate that into policy which provides access to vaccines to all across the world. Next slide, please. So the IVAC team consists of 50 faculty and staff, and hundreds of students have come through our ranks, and we're very actively engaged with student teaching, both within Johns Hopkins and also internationally. It's now over 10 years. It's now 2021, so well over 10 years that we've been working in countries all over the world and collaborate with partners in every continent. Next slide, please. Okay, so the issue of today's topic relates to really positioning us and our thinking on where we are in this unfolding pandemic. It's been a tough year. It feels like much more than 1 year since all of this unfolded, and it really changed our lives remarkably. But the key issue, and the one we'll be discussing today, relates to where we are now with respect to vaccines. So this next two slides really just look back over this past year to see what got us to where we are today. Within the United States, there was a government program, a taxpayer-funded program called Operation Warp Speed, which brought us to the point where we have a number of vaccines that are safe and efficacious and being rolled out both here in the United States and then in other countries around the world also. The name Operation Warp Speed, was a choice that I don't know which marketing guru made it, but clearly it tried to convey the idea that nothing would stand in our way and we would go as quick as we could towards halting the pandemic as best we can. But clearly the connotations in the public have been of concern for the speed and rapidity with which this has been reached. So just maybe a brief few words on this. Many of you have already thought about this and considered this, but the very large investments that were made in the development programs around these vaccines allowed the trials that were undertaken to be very large in scale and in scope, to be inclusive of a diverse range of participants, both in terms of race and ethnicity and also in terms of risk profile, comorbidity and so on. And the magnitude of those trials meant that we could recruit very large numbers very quickly. And sadly, with the very high prevalence, the high burden of COVID-19 disease, it doesn't take long under those circumstances to accrue cases. The duration of time that a trial takes is really about accrual of the outcomes of interest. And so with very ubiquitous event rates, many people becoming ill with COVID-19, it doesn't take long before we start to see differences across randomized trial arms, particularly when those interventions are efficacious. You start to see very dramatic effect sizes quickly. And that allowed us to achieve fairly precise estimates quickly around efficacy. And the large size also allowed us to understand safety within the immediate term, the short term, and now into the intermediate term as well, as those evaluations are continuing. Once the vaccines have achieved emergency use authorization, they're now in widespread use. And ongoing safety surveillance is, of course, occurring as part of post-licensure pharmacovigilance. Next slide, please. So, this is just a summary of the entire timeline of this last year. In December, when the first cases were identified, by the beginning of 2020, a public health emergency of international concern was declared, following which it was declared to be a pandemic. The Chinese scientists released the sequence of the SARS-CoV-2 virus, and really within weeks, literally within a matter of weeks, the first candidate vaccines entered phase 1 clinical trials and went through those trials through to phase 3. In December of last year, the FDA authorized initially Pfizer and then other vaccines and provided emergency use authorization. Similar authorizations were given in other countries around the world, and then also by the WHO for other vaccines as well. And we're now at a point where hundreds of millions of doses have been given internationally, over 100 million of those in the United States. And we're now standing at this busy time of a very difficult and complicated global rollout of vaccines. Next slide, please. So the vaccine rollout is progressing haltingly, but it is increasing in speed in many settings, including in the US. The global rollout has commenced through the COVAX facility, which is the international collaborative facility to provide affordable access to vaccines for all nations. And the aim is to provide at least 20% of every country's population's worth of vaccines, but also state-based procurement is occurring. So even countries that are eligible for COVAX assistance, many of them are also procuring through other channels and investing in increasing the availability of vaccines in their countries to their populations. And at the moment, we're at a stage where the global demand, and even in the US, the demand exceeds current supplies. And supply is increasing through important collaborative agreements between companies, pharmaceutical companies that initially perhaps were producing rival products and are working together to produce vaccines of previous competitive companies. And we're seeing that in the United States, and we're seeing that in India, we're seeing that in Australia, we're seeing it in many settings. And all of that is in an attempt to maximize the global supply to meet the demand. And that demand is high even in the face of ongoing concerns around hesitancy regarding safety and hesitancy of vaccines in general. The demand for COVID-19 vaccines remains at a high. Now that we have rollout in many countries, and in some countries very high rates of coverage, we have evidence of real-world impact and effectiveness for severe disease, and more recently also on asymptomatic infection, which is clearly a very important outcome if we're going to curtail transmission, achieve concepts similar to herd protection and so on. Having efficacy or real-world effectiveness, I should say, against infection is really important. We have trials that are currently expanding to special populations, to pregnant women, to children, and companies are exploring the possibilities of new generation vaccines, those that perhaps are administered more easily, those that have heterotypic protection against viral variants. We'll discuss some of that in today's session, and potentially ones that induce long-term protective immunity as well. Safety surveillance, as I've mentioned, is ongoing, And regulators around the world are busy responding to safety concerns and responding to mechanisms for licensure of second-generation vaccines, given the ethical challenges that nowadays it's no longer possible or appropriate to conduct large-scale trials where people receive placebo, given the availability of vaccines. So there are remaining challenges, the challenges ahead. We clearly have an emergence of variants of concern, or some of those may be variants of so-called high consequence, where they transmit easily and potentially have immune escape, perhaps more severe and so on. We'll hear more about that in detail. We still have issues around inequitable vaccine access, but also concerns about vaccine uptake by certain communities, by subsets of communities and so on, and ongoing concerns around hesitancy and ongoing dissemination of disinformation on social media and in other networks as well, which need to be addressed thoroughly and honestly and transparently. There is an ongoing need for masking and distancing, and the continuation of those practices will allow even moderately good vaccines to have greater overall impact on community transmission. But clearly we are facing questions of tolerability and the costs of ongoing strict pandemic policies that have resulted, it has to be said, in very severe economic burdens and on health and negative health outcomes on populations also. And getting that balance right is both an ethical challenge, a programmatic challenge, and a very difficult policy decision, which is open for debate and around which there are dissenting and reasonable views as well. Okay, so next slide, please. Okay, so first I'd like to introduce Tom Shimabukuro from the CDC. We're very pleased to have you. Thank you for your precious time, and we'll be happy to hear from you about COVID-19 vaccine safety evaluations. Thank you.
Thank you for inviting me. I appreciate the opportunity. Today I'm going to be giving an overview of vaccine safety surveillance. It's going to really be a surveillance-focused presentation, which is going to talk about systems and some of the early safety data. Some of the data I have runs through about the middle of February, which is when I last updated the Advisory Committee on Immunization Practices. And it's limited to the 2 mRNA vaccines that were in use at that time. But I think the findings are still quite relevant. Next slide. Next slide. So I'll be giving an overview primarily of CDC safety systems. And we have basically 3 core programs in the Immunization Safety Office at CDC: the Vaccine Adverse Event Reporting System, the Vaccine Safety Data Link, and the Clinical Immunization Safety Assessment Project. I'll describe each of those. But I'm going to start off with a new system called vSafe, our after vaccination health checker. Next slide. So vSafe was set up by CDC just for COVID-19 response. It is a smartphone-based active safety monitoring system that uses texting technology and also online surveys. Next slide. So this is a sort of a high-level schematic of how vSafe works. vSafe is a voluntary self-enrollment program. So individuals choose to enroll or register in vSafe. We hope at the point of service when people get vaccinated or shortly thereafter. They can do this by scanning a QR code or typing in a URL, which takes them to a registration page. They register, and that kicks off the text messaging process. So we send text messages with web links embedded in the message to online surveys. And during the first week after vaccination, we follow up every day and ask a series of reactogenicity questions and health impact questions. After that first week, we move to weekly through 6 weeks, then at 3, 6, and 12 months. When a person gets their second dose, that process basically resets. So we follow up people. The plan is to follow them up for a year after the last dose of a vaccine. On any health check-in, we ask about clinically important health impact events, and if a person reports receiving medical care, then we follow up in a separate system called the Vaccine Adverse Event Reporting System to get a report. We also have questions that allow the individuals to self-identify as pregnant, and for these individuals, we contact them outside of the vSafe system by telephone to enroll them in a pregnancy registry. Next slide. So these numbers are a little bit dated, but at the time, mid-February, there were about 55 million people who had received at least one dose of a Pfizer, BioNTech, or Moderna vaccine, and we had about 3.9 registrants that had completed at least one health check-in, and about 30,000 individuals that had self-reported they were pregnant at the time of vaccination. Next slide. And so this is a this is from an MMWR showing some initial VSafe data, and it's primarily focused on reactogenicity. And what you can see here, if you focus on the dose one, day one for each vaccine, I think the take-home message is these vaccines are fairly reactogenic. There is injection site pain, and there are systemic symptoms reported like fatigue, headache, myalgia, and chills. And this is consistent with what was observed in the clinical trials. Then if you want to focus on the middle two columns there, those are for the Pfizer BioNTech vaccine. For that vaccine at that time, we had dose one and dose two information. And the take home message there is if you look at the systemic symptoms, the self-reported systemic symptoms, there is substantially more systemic reactions reported after dose two, in some cases 3 to 4-fold higher on day one, which is the day that most reactogenicity occurs. And that's also consistent with what was observed in the clinical trials. There are more systemic reactions after dose two for these mRNA vaccines. Next slide. So now I want to move on to our vaccine adverse event reporting system. This is a long-standing established national surveillance system. It's been in place for 30 years. It is a spontaneous reporting or passive surveillance system, meaning we depend on individuals to send reports into VAERS. Anyone can report. These are healthcare providers, patients, parents, caregivers, and manufacturers. And basically, VAERS is a passive recipient of these spontaneous reports. Next slide. So VAERS essentially covers the entire US population. All 320 million US residents who are eligible to get a vaccine are potentially in the covered population. That's all ages, races, states, jurisdictions, healthy people, those with chronic health problems, etc. Next slide. And VAERS accepts all reports from everyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. We'll accept any report from anybody, and it'll get into the data and it'll be analyzed. The key strengths are that we can rapidly detect safety problems and can detect rare adverse events. The limitations are those of passive surveillance. The main limitation is generally we cannot determine cause and effect from VAERS data alone. Next slide. So at the time of this analysis, there were just over 104 total reports, of which 94% were non-serious and about 6% met the regulatory definition for serious. That's the definition that FDA uses. And that breakdown, 94 to 6%, is pretty similar to what we see for other vaccines that are administered to adults. So flu vaccine, shingles vaccine, pneumonia vaccine, that 90 plus non-serious is consistent with what we would expect. Next slide. And now here's a side-by-side comparison of the most common reported adverse events for the Pfizer-BioNTech vaccine compared to Moderna. As you can see, these are remarkably similar, and systemic and local reactions are the most commonly reported adverse events. There were no empirical Bayesian data mining alerts detected for any adverse events. And so this basically reinforces what was observed in our VSafe monitoring system and is consistent with what was observed in the clinical trials. Next slide. So now I want to move on to the Vaccine Safety Data Link, which is a collaboration between CDC and 9 participating integrated healthcare organizations. These tend to be large staff model HMOs, many on the West Coast, a lot of the Kaiser Permanente sites. And we have data on over 12 million persons per year. Next slide. So VSD is primarily an EHR, an administrative administrative data system. It has information on immunizations, encounters with the healthcare system, outpatient, inpatient, emergency department, procedure codes, birth and death certificate information, and demographics, all linked by unique study IDs. We also have access to electronic health records and charts should we need to go in and review a case to confirm it actually is a case or to confirm it's an incident case when we do our safety monitoring. Next slide. This is just on the left-hand side there. You see the pre-specified outcomes that we are doing in our vaccine safety data link monitoring. Unlike VAERS, where we're looking at anything that comes in the vaccine safety data link, we specify outcomes in advance. So it's not data mining, it's more an hypothesis generation. It's more hypothesis testing. We have a reason to include these based on historical or general interest or interest based on natural disease outcomes. We do these weekly sequential analyses, and our preliminary results for 2 of the analyses we've done, an unvaccinated concurrent comparator and a sequential vaccinated concurrent comparator, are that there were no statistical associations or statistical signals for any of these pre-specified outcomes following COVID-19 vaccination. Next slide. So I'll just briefly mention our clinical immunization safety assessment project. This is a collaboration between CDC and 7 participating medical research centers. And this group does detailed case evaluations at the request of U.S. healthcare providers. So these are particularly difficult or challenging adverse events in patients where healthcare providers are asking for assistance. And the main assistance we give is on how to manage the patient moving forward with respect to future vaccinations. And they really do a very detailed grand round style review of these complex cases and provide support and guidance to healthcare providers. This group also does clinical research as well. Next slide. So I want to spend a little time talking about COVID-19 vaccine safety in pregnancy because I know that's a topic of interest to many. Next slide. So this is a repeat of a previous slide where I mentioned that there are about 30,000 individuals who self-identified as pregnant when they were vaccinated in our VSafe monitoring system. Next slide. So VSafe participants who report a pregnancy are actively contacted to be enrolled in the pregnancy registry. They're contacted once per trimester after delivery and when the infant is 3 months old. And you see the outcomes of interest there, which include both adverse pregnancy outcomes, birth outcomes, and neonatal outcomes. Next slide. So here's some data on the enrollment, and I will say this is enrollment to date is like approaching 4,000. So we continue to enroll individuals in the pregnancy registry and have actually been encouraged by the amount of vaccination given in pregnancy. At the time of this analysis, there were 275 completed pregnancies, including 232 live births, and some of the other outcomes include miscarriage, stillbirth, ectopic, tubal pregnancy. Next slide. And this is just an overview of the outcomes for pregnancies in which we have outcomes, and it's still pretty early, and most of the vaccination for outcomes occurred in 3rd trimester just because pregnancies do have to progress to an outcome. But we have pregnancy outcomes here, miscarriage, stillbirth, some pregnancy complication outcomes, and then some neonatal outcomes. And what I want to point out is in the first column to the right there, we have background rates from the literature for these outcomes. And then in the last column, we have the VSafe pregnancy registry overall proportions, because we want to put these proportions into perspective with what we would expect based on known background rates. I think the take-home message here is for the adverse pregnancy and neonatal outcomes, they are within the range of the background rates that we know from the literature. Next slide. And I'll just mention briefly some VAERS data. So these are spontaneous reports that pregnant women send in, and these are just some of the basic characteristics of the reports. I'll say most of these reports in VAERS involved vaccination during the 1st trimester. Just over half of them involved 1st trimester vaccination. Next slide. So notably, if you skip down to the bottom, just because these are pregnant women doesn't mean they have normal adverse events that anyone else would have. In fact, almost 3/4 of these reports involved non-pregnancy specific adverse events, things you would expect in anybody, headache, fatigue, chills. Of the 27% of these 154 reports that were pregnancy or neonatal specific conditions, spontaneous abortion or miscarriage was most commonly reported, and then there were smaller numbers for these others. I'll just mention that spontaneous abortion is actually a very common occurrence, an outcome of pregnancy, and based on presumed doses administered in pregnant women, we don't think that there is a problem with the reporting rate here. It's well below the background rate that we would expect, just due to chance alone. Next slide. So I want to acknowledge the following investigators from these organizations that help with this analysis. And I just want to close by saying that as of today, there are over 60 million doses of vaccinations given for each of these mRNA vaccines, and over 20 million individuals who have received the full dose. So there has been a lot of vaccination of the Pfizer, BioNTech, and Moderna vaccines. The safety profile is consistent with what we would expect based on the clinical trial data. There have been reports of severe allergic reactions or anaphylaxis, but the reporting rates for anaphylaxis after either of these vaccines, which I'll add can occur after any vaccine or any drug, are consistent with what we would expect based on rates for other routinely recommended vaccines in adults. Other than that, we have not observed any safety signals or any safety problems for any serious adverse events. The data on vaccination and pregnancy is early and it's limited, but the data that we do have indicates that there are no safety problems with respect to pregnancy outcomes or neonatal outcomes in pregnant women. And overall, we think that these safety results for these vaccines are reassuring. Next slide. And so I'll turn it over to Dr. Barzev. Go ahead.
Great, thank you so much. Just to note that I do see some questions coming through in the chat and in the Q&A, so we will address those at the end of the presentations. But let's move on to the next topic of discussion, which is the emergence of variants. Variants are a normal part of biology, but some of them are of concern to us in public health world. So I'd like to hand it over to Professor Pekos, who can talk us through what makes a variant of concern and how should we be thinking about the different variants that are emerging. Thank you, Andy.
Thanks very much, and thanks for the opportunity to talk about COVID-19 variants. Next slide, please. So here's just a dashboard. It's a little bit out of date, but just to tell you that, remind everybody what they should already know. We're not out of the woods yet in terms of COVID-19 cases. Globally, we're seeing large numbers of cases. Next slide, please. And if we look at a national level, we can see some of the trends that are starting to concern us these days. The USA has bottomed out in terms of a plateau at a very high rate of cases, though. The number of cases going on in the US right now, it matches the summer peaks that we were having last year. You can see other countries here, India, Germany, Argentina, Italy, are all undergoing spikes in cases. Some of those countries are actually resorting to lockdown measures again to limit the virus spread. And of course, Brazil is a country that's undergoing a true public health crisis right now with virtually uncontrollable virus spread in that country that's really taxing their healthcare systems and hospitals. So we're not out of the woods yet with the virus, and we need to have all of our tools in place to make sure that we limit the number of cases that are occurring. Next slide, please. So what is a variant? This term has really come to bear in the last few months in particular, but let's start with the fact that viruses always mutate. And when a virus accumulates a mutation, that's when we usually call that a variant. Now, most of those mutations do virtually nothing to a virus's property. In fact, they've been used very extensively over the first year of the pandemic to actually trace who has gotten infected from who, where viruses are moving internationally. So they've provided very useful information that has helped us do the genetic epidemiology in terms of the viruses that are spreading in the population. Next slide, please. But every once in a while, mutation can occur that can actually change the properties of a virus. And so you've heard some of these variants referred to by UK variant, which is a strain of virus originating in the UK that seems to be associated with increased transmission. We have these Brazil and South African variants, which have mutations that can alter the ability of antibodies to bind to the virus. And then we're going to be hearing more and more about other variants. Oftentimes they'll be labeled with numbers, but they oftentimes have similar mutations to those above variants, but are not genetically related to them, meaning that they've occurred spontaneously in other parts of the world, suggesting that the virus is accumulating some core set of mutations that are giving it some advantage in terms of infecting humans, because the virus is doing this independently. Next slide, please. So what's the critical thing to know about SARS-CoV-2 variants of concern? Well, they really fall into three categories. Some of these variants appear to spread more easily than older SARS-CoV-2 strains in the virus population. Others have mutations that make the virus look slightly differently to your immune system. So perhaps the immunity induced by vaccination or previous infection won't recognize these viruses as efficiently. And then perhaps the most concerning variants are ones that are increasing disease severity, meaning that if you get infected, you have a higher likelihood of generating very severe disease or hospitalization. So we have examples of all variants showing these changes in properties. But it's important to note that any one of them are a concern to us, because anything that causes increased numbers of cases will result in more hospitalizations and deaths, even if the virus isn't causing more severe disease. So all these are important because while we're rolling out the vaccine, it's very critical for us to maintain our public health interventions such as masks, physical distancing, avoiding crowds, because we need to reduce the number of cases that we're seeing, as well as start to immunize the population. Next slide, please. So, of course, the big question that everybody asks, are the vaccines able to provide protection against the variants? And we're seeing several studies that have been done in countries where variants are present. And so the answer is yes, especially when you consider the most important factor that we're trying to immunize against, and that's severe disease. So all the US approved vaccines have shown efficacy in preventing severe disease against the older strains as well as against the variants. Now, there may be some variation in vaccine efficacy against mild disease, but certainly the critical thing that we're looking at right now is that protection against severe disease, because we want to make sure that we're limiting hospitalizations and deaths from infection. Now, we need to continue to track the new variants that are emerging to determine whether changes to the vaccine are necessary and whether some of these mutations the virus is picking up really move it to a level where the vaccine efficacy is really starting to suffer tremendously. But for the time being, the vaccines are providing protections against the variant viruses. Next slide, please. Now, of course, everybody has questions about vaccine availability, which vaccine, how many doses, how are they distributed? We're entering a time now where we're going to be seeing a major scale up in our vaccination efforts. So everyone needs to pay attention to their local public health authorities to find out all the information about getting in line for a vaccine. But I'll emphasize what I just said in the last slide. We shouldn't be shopping around for vaccines. Whatever vaccine is available in your area, when it's time for you to line up for it, I suggest line up and take whatever's available. They'll all be useful in terms of getting our population immunity up and protecting us from that severe disease. And most likely, they'll also be protecting us significantly against milder disease. An important question that has to be addressed, though, is equity in vaccines. We need to get the vaccine into populations that have suffered a larger burden of disease from this pandemic so far. The elderly is one population, but there are a lot of social, economic, and racial factors that are contributing to severe disease, and the vaccines need to be distributed in ways that are affecting those most vulnerable populations as well as to the general public. Next slide, please. Now, the final point that I wanted to make is, if you've had COVID-19, are you still susceptible to the new virus variants? And the question is, Probably not. You have some immunity that will recognize that. But if you've been infected with COVID-19, you should still line up to get a vaccine dose, because the vaccine will induce stronger and longer protection from immunity than infection appears to do. You may only need one dose of vaccine if you've been infected to get that stronger immunity, but certainly the fact that you've been infected shouldn't preclude you from lining up to get your vaccine when you're eligible for it. Next slide, please. All right, so our take-home messages are really simple. Vaccine availability will be improving every week going forward. We'll be continuing to monitor for new variants and COVID-19 vaccine efficacy. And vaccines, along with public health interventions, will turn the corner on this pandemic. But right now, we need to be doing both, and we need to be doing both as effectively as possible to make a dent in the number of cases that we're seeing. All right, and with that, I'll thank you for your attention, and I think we'll open it up to questions now.
Great, thank you very much. Great summary. There were a number of questions that have come in through the chat, and also ones that have been emailed to us earlier. Let's first focus on questions regarding safety, but I do just want to make a general comment. Some of the questions that are coming in are more of a clinical nature questions, or specific individual advice questions. And I just want to kind of give an overall advanced apology. We can't answer personal clinical questions, and I would advise all persons with concerns or special cases with regards to their own immunity to speak to their own physicians. But I do welcome questions, particularly questions that have to do with either the science or the public health aspects, rather than ones relating to personal advice, if possible. There was a question: what would the panel say to a pregnant woman who has low or moderate risk of contracting COVID? Should that woman be offered the vaccine? Tom, maybe you can take that question.
Well, the current recommendations are that women may choose to be vaccinated. There is evidence that COVID disease is more severe in pregnant women compared to non-pregnant women of reproductive age. And there is also some evidence that COVID infection during pregnancy increases the risk of adverse pregnancy outcomes. So I think that's a conversation that I think women should have with their healthcare provider. But the guidance from CDC is women may choose to be vaccinated against COVID when they're pregnant.
Yeah. Phase 3 trials that are, or I should say randomized trials that are including pregnant women are underway. And we hope that we will have results from those trials reported in the next couple of months. But in the meantime, we do have the data from the tens of thousands of pregnancies that we heard today, that Tom described, and also in other settings around the world where pregnant women were vaccinated. So those data are emerging, but I guess more will come. There was another question about the protection that newborns may receive from vaccination of the mother during pregnancy or during lactation. Tom, would you like to think about that?
I think all I can say about that is that there is some evidence that of maternal antibody transfer to the developing baby. So at least there appears to be some evidence of a potential benefit to the child from maternal vaccination. And this is consistent with what we've observed for other vaccines that we recommend during pregnancy.
Yep. Thank you. There was a question that came through the chat regarding if somebody already has had COVID-19 disease in the past, presumably have an immune response. What do we know about vaccine safety in them? Is reactogenicity higher among persons who've had previous COVID disease?
So there is anecdotal reports and anecdotal evidence of increased reactogenicity, primarily systemic reactogenicity in individuals who have been previously infected, particularly in individuals who have been recently previously infected. But right now, that is mainly anecdotal, and we are looking at ways to see if we can analyze that in a more systematic way.
Thank you.
And if I could add, though, that I think that's what I briefly mentioned as well, too, that a single dose of vaccine in people who have infected is shown to be quite efficacious in terms of inducing the antibody responses. And again, there's just a couple of studies on that population with small numbers, but it's all suggestive that the infection can serve almost as the equivalent of that first vaccine dose. And so you can get when you get your first vaccine dose, that boosts those immune responses to very, very strong levels, which we assume will be mediating very long-term protection.
Andy, would you say that those data are akin to immunogenicity trial data rather than efficacy trial data? We have good immune responses for people with past COVID from a single dose, but that doesn't necessarily mean that people should avail themselves of only one dose. They should probably have the full course, or how would you interpret those data?
Yes, I think right now the recommendation is that everybody gets the full course because we don't have the efficacy data. It's an important point to emphasize. Much of what you're seeing about reports of vaccine data is from in vitro studies where we take antibodies from vaccinated people and we look at how they react to the virus in laboratory settings. That is an important piece of the puzzle, but it's not everything that we look for. The true vaccine efficacy studies where you follow people and see if they're infected will take some time to put together. So the in vitro data that we think about is just the first piece of the puzzle that helps us sort of prepare for the vaccine efficacy data and interpret that better.
Yeah. Questions on variants that have come through as well. Perhaps we can address some of those. There's been some evidence that variants may be converging, quote unquote, and that perhaps down the road we're looking at a broader booster to cover these variants. Do we see evidence of this? I'm not sure whether the question refers to convergence in the sense of convergent evolution, which I think you kind of mentioned in passing, Andy, that we're seeing similar mutations occurring in unrelated lineages of the virus. Or perhaps the questioner is asking whether or not mutations will co-occur. So mutations that confer immune escape will co-occur with mutations that increase transmissibility, and will viruses share those mutations in much the same way that bacteria may share plasmids, for example? I guess either of those are interesting questions.
Yeah, I think the fact that they are seeing multiple viruses in different parts of the world coming up with the same mutation is telling us these mutations are an advantage to the virus in some way. I think what we're really going to be looking for in the next few weeks in particular is understanding if you've been infected with a variant, how good is your immune response to that variant, and will that protect you in the future from the older as well as the newer strains? So there's some data that needs to be generated there. I think it's important to mention that virtually all of these variants are single mutations, and so they won't eliminate all of the immunity that the vaccine gives you. It just eliminates one small part of it. So we certainly don't expect from the data we've seen so far to see a variant that is completely resistant to vaccine efficacy, to vaccine-induced immune responses. But again, that doesn't mean we shouldn't monitor them, because as the virus accumulates one, perhaps two or three mutations, that may take it to an area where we really are concerned about vaccine efficacy that may then result in a change in the vaccine formulation.
Yep. And we do have a question about what's known about existing vaccines in preventing severe disease and death among people infected with variants. They mentioned B117, the UK variant P1, Brazil, and B1351, the South African variant. And Andy, you mentioned that for severe disease, we all are confident that the vaccines will retain their efficacy, but there may be differences for mild, moderate disease. Perhaps you could expand on some of those differences.
Yeah, absolutely. So the best data on vaccine efficacy with respect to infection with variants comes from South Africa and from Brazil and the clinical trials that were done there. And their overall vaccine efficacy was lower in terms of protection from mild to moderate disease. But importantly, in all those situations, protection against severe disease, which sometimes is differently defined, but essentially is from hospitalization and from death, was maintained at a very high rate, even in people that were infected with the variants. And so, these vaccines give your immune system a head start. And no vaccine ever protects you 100% from infection and susceptibility to infection, but they give your immune system a head start. And even in the case of these variants, the vaccines are giving your immune system enough of a head start to really protect you from those severe disease outcomes, which are, again, as I mentioned, the really critical things that we want these vaccines to protect against.
Yeah, I mean, a couple of things. I think the J&J vaccine had a Brazil arm to the trial, and that was at a time when the P1 virus was dominant there. And I haven't seen them report the actual variants, but certainly the efficacy reported from the Brazil population was not particularly different from the overall trial results. And so that's reassuring. And I guess B117, although it transmits more rapidly, I'm not sure that it has manifested any immune escape. So what we've seen is that many of the vaccines, even the wholesale kill vaccines, have good efficacy against B117. So that's reassuring. But perhaps beyond the personal individual level of protection, there's also the public health question. And when we have a virus that's very rapidly transmitting, even for a given efficacy against that virus, it still helps if we have masks, distancing, and so on. The more we can do to reduce transmission, the better. And for a more transmissible vaccine, for a more transmissible virus, for a given vaccine efficacy, it would be helpful if the population continued to practice those other non-pharmacological measures. What are your thoughts on the public health approach to increase transmission?
I would agree with you 100%. We haven't reached the stage in this pandemic where we should rely on only one means of protecting people. There are still too many cases, particularly in the US and many of these countries, as I showed in some of the graphs. There are too many cases to simply take away these multiple levels of protection that we have put in place. So I know some people say, well, I've been vaccinated, why should I wear a mask? Again, too many cases going on in the population. We need to have multiple things in place to make sure we reduce the number of cases that we're seeing. And so that's why masking, social distancing is still going to be important until we get those case numbers down and until we get a large percentage of the population vaccinated so we can see that the community benefits of the vaccination profile. So things are coming, they're on their way, but we just haven't reached that level yet where we can relax things to the degree that I know most people want.
Mm. We've had a question for both the panelists. We had a question coming around second generation vaccines, so novel vaccines, either ones that are less reactogenic, more easy to take, or that are more thermostable, they don't require very cold chains, or indeed ones that have proven efficacy against variants. What would be the regulatory mechanism to allow those vaccines to achieve either emergency use authorization or eventually full licensure, given that there are existing vaccines, given the absence of known correlates of protection, at least for now? What are your thoughts? Either one could take that question.
I would have to defer to the FDA on that. I don't know if Dr. Pecos has an opinion on that. To me, that would be more of an FDA issue.
Yeah, I would agree. I think everything that we're hearing from the FDA suggests that if you've got an existing approved vaccine and you want to change it to match a variant or to update it, that you won't have to go through the same clinical trials that the first generation went through. They'll have to go through a smaller trial for efficacy and for safety, I should say. And then they'll be able to roll that in a similar way that we do with our flu vaccines, whereas we can update a strain of flu vaccine from one year to the next without going through an extensive 6 to 9 month, 40,000 person clinical trial. Again, it's building on the data that's already out there. But I think all of this will be coming to light soon, because I know that at least Pfizer is starting to do some immunizations with variants to try to get at this issue of whether a booster is needed.
Yeah, and perhaps just to add to that is that even if regulatory approval is given, I think it'll be important to consider what the public perception will be. And if we've got one vaccine still in rollout and then we start to replace it with another vaccine that's potentially considered to be better or described to be more efficacious or have some advantage, it can throw the whole business into a very big mess and harm confidence in the community. So these things have to be very thoughtfully planned and communicated and explained. And there really has to be a good cost-benefit sort of tipping point to say, okay, we've got a better vaccine that's that much better that it's worth those additional costs of further rollout. So it's a complex question rolled into that. Yeah. There was a general question about, perhaps Andy, you could take this. What are we seeing regarding the duration of protection from existing vaccines? This is a short question, but it contains a lot. So perhaps you can start to unpack some of those.
Yes, it does. We'll start by saying that most of the clinical trials of people who were of the vaccines that are available in the U.S. Have enrolled people for 12 months to 24 months. So we will be following immunized individuals for long periods of time to see how their immunity lasts. Right now, the strongest data so far has been about the 6-month data, which shows very good responses in all vaccinated individuals, even across age groups. And that data suggests that the response is stronger and more long-lived than the response to infection in certain populations. So far the signals are really good that the vaccine is inducing a good, strong, long-term immunity, but we'll see more of that coming at the 9 and 12-month markers, where those populations will be brought back into the clinics and their blood will be tested to see how their antibody levels are staying.
Yeah, I mean, there are emerging data from people who were infected early in the pandemic, particularly now emerging around cellular responses, T-cell responses, and their longevity and their breadth and so on. But again, it's not entirely straightforward to infer from people who with wild-type infection to people who are vaccinated. But there are some lessons that could be learned. So I think, you know, the immune response is rich and multifaceted, and we're learning more as time goes on. But clearly, we've only been here for a year, and so it's hard to know beyond that. Yeah. A policy question that came in, either of you, just to throw your hats on this one into the ring: give a single dose to more people, or give 2 doses to fewer people to achieve high levels of protection? What would your opinions be?
I don't think I'm going to offer an opinion on that as a CDC employee. I think I'll refrain from commenting on that one.
Sure.
And I'll just say that I think when you have a known vaccination regimen that gets you to 90+% efficacy, that is a fantastic thing to have. So I think that you want to get to a high level of immunity as fast as possible. There may be alternate ways to do this, but right now that regimen is the best way to get to that level. And since it seems like we're solving some of our supply problems, it may be that sticking to that approved regimen is the best way to go forward to get that strong population immunity.
I'll just add that, I mean, CDC has recommendations through its advisory committee on immunization practices. And I mean, those are the recommendations for, you know, completing your vaccination series.
And I would just only add that the evidence that's been used in the UK to consider this more thoroughly is based on the trial results, the randomized trial results with the AstraZeneca vaccine. And that was in the context of a randomized trial where some recipients received it out at 12 weeks as a gap between doses. That's not the case for the trials in the US. The trials in the US adhered to protocol and to the time difference. So the advantage of that is that we have very rigorous results. The so-called disadvantage of it is that we don't have those deviations of longer upon which to base evidence. But the evidence for the vaccines in use in the US is to receive 2 doses. And I will throw my hat in the ring. I think we should go with the best available evidence when making policy on that. Tom, we've had some questions come through on headlines in this past week about blood clots and the EU having concerns. What evidence do we have around this from surveillance in the United States? Let's, for the sake of argument, assume that there is a causal association. How does that compare to the risk of adverse events from COVID-19 disease itself? And what would be the recommendation in light of what's known on this issue?
So I can't really comment on the findings with the AstraZeneca vaccine in Europe. I'm not privy to that information. That vaccine isn't authorized in the United States. I can say that coagulopathy disorders like ITP, DVT, pulmonary embolus, ischemic stroke, TTP, these are pre-specified outcomes or adverse events of special interest that we are monitoring very closely. And to date, we have not seen any safety signals or any disproportionality or any evidence of an increased risk, but we'll continue to monitor them very, very closely, you know, as as we continue to vaccinate with the existing vaccines and as new vaccines come online.
I would like to address an issue which is increasingly resonant in social media and really arises from disinformation, but perhaps just to hear from you both on this issue. The question of fertility, people planning to become pregnant, should people be concerned to receive the vaccine before becoming pregnant? Is there any evidence that vaccines, any of the vaccines that we have evidence for, in any way interfere either empirically through empirically observed data or through biological plausibility with human fertility, or indeed with non-human primates or other animals? What's known on this issue?
So I will say we don't have any evidence of a safety problem with respect to fertility, and I cannot think of any biologically plausible reason why for these vaccines there would be any issue with fertility. I'll mention that COVID-19 can be a serious illness, and there's evidence that it can be more serious in pregnant women and can be harmful to the pregnancy. So I certainly think if you're trying to get pregnant, or if you are pregnant, I think following the CDC recommendations and getting vaccinated it would be a good thing to protect yourself and your developing baby.
Andy, your thoughts as well?
I agree completely with what Tom just said. There's really no biological plausibility with connecting the vaccine with reproductive issues. And I think that, again, what Tom said, the disease itself has shown much stronger signals of many problems than the vaccine has. And so the vaccine is certainly an advantage to protecting the population from all of the major as well as the minor effects of COVID-19.
Yeah, I mean, one other aspect I think that's relevant for this thoughts on this is that despite the fact that we're seeing COVID-19 disease affecting pregnant women more severely, we've not had, not that I've seen, any reports globally of a sudden surge in infertility around the world in people who've had COVID disease. And so if there was biological plausibility to the idea that naturally induced antibodies to the spike protein can somehow interfere with fertility from the vaccine, then it should also happen from the virus, and it doesn't. And we've had millions and millions and millions of people infected around the world, and women of childbearing age, and that's not emerged as an issue. And that, again, argues against, even on empirical grounds, the association there. So yeah, I agree with all of you. I'll finish off perhaps with one last slightly politically tinged question regarding when is it appropriate to give an emergency use authorization? If we have evidence of safety that we're so confident in, and if we have evidence of efficacy, which is so precise, as we say, enough to roll out a vaccine, why not give full licensure to a vaccine? Why not provide, the full stamp of approval? Why hedge our bets with an EUA? Any thoughts on that question?
I guess I'll. I think FDA has FDA has their criteria for authorizing a product under emergency use authorization, and determining when there's a policy need. So I think I would defer to the regulators on when it's appropriate to authorize something under emergency use authorization.
Yeah. I mean, Andy, you had mentioned that the trials are ongoing, and we really have to wait for those trials to conclude so that we can talk about longevity, so that we can talk about longer term effects. And it seems appropriate and normal that full licensure will wait till the reporting out of the end of the trials, but that thousands of people were dying every day before EUA or at the time of EUA, and it becomes unethical to not give a vaccine if we know enough about its safety and know enough about its efficacy. So I guess there's a public health ethical question of when is enough knowledge enough to start saving lives with a vaccine that we know is safe and efficacious, but continuing to study it and maintaining a very diligent scientific eye over it before giving it the final stamp of approval. I think that seems to be eminently reasonable and appropriate. Final thoughts, Andy or Tom, about any?
And I agree with everything you said. I think what's important to note for everybody out there is that we're not stopping studying these vaccines. The monitoring of vaccinated individuals, safety as well as efficacy, as well as immune responses is ongoing. And in particular, there's a very important emphasis on age, race, and those other demographics that have been shown to be so important with respect to severe disease. So this is an ongoing process. And just because it hasn't reached that bar yet of formal approval doesn't mean that these things aren't being tracked. It's important to get these vaccines out, continue to monitor these. Eventually, we will get to a stage where these will be approved vaccines because they're all showing all the signatures that would make them approved vaccines. But we have to act now to really get our case numbers down, and this is going to be one of the most powerful tools to do that.
I'll just mention that these are large clinical trials for these vaccines, and CDC and FDA and other partners have implemented the most intense post-authorization safety monitoring program in the history of the United States. The scope and the scale of our safety monitoring has really never been seen before. So the U.S. government is being vigilant in ensuring that these vaccines are safe, and there's other monitoring going on, including effectiveness and monitoring other programmatic areas like accessibility and doses administered.
Great. Thank you. Thank you both so much. We've had great engagement from the audience and wonderful questions, and I'm sorry that we couldn't get to them all. Clearly there's a lot of thought out there in the community, so it's wonderful to have the expertise of both of you available to the audience and to us. And I'd just like to close by thanking you both very much for your time and expertise. It's been a pleasure.